Salamat Pagi. So sorry that
Selamat
not there
pagi.
with you in Surabaya this year. But I want to talk a little bit today about some new information about what to do with acute MI, just to let you know that there are some things going on where there's more than just opening up the artery. Those are my disclosures. So just a little bit of history, just to remind you that our whole understanding of acute MI, the fact that it's in a completely occluded artery, is really a relatively recent finding. Up until 1980, there was a lot of debate about what was going on in acute MI, whether it was just spasm of a very tight lesion or whether it was actually thrombosis, as a lot of people suspected. And Marcus DeWood in Spokane, Washington, did the very simple experiment to sort of solve this dilemma of what was going on in acute MI. And that was that he just took everybody who presented with a STEMI to the cath lab. And what he found is what we all now know is that most of the time, 90% of the time, what you're going to end up seeing is a completely occluded artery. And we know that that is caused by a thrombus. Well, at the same time that DeWood was making that observation, people at Duke, Reimer and Jennings, were looking at animal studies and doing another sort of simple experiment, which was just tying off a coronary artery in an animal model and then releasing it at varying time points. And what they found was that if you had a relatively brief duration of ischemia, say 40 minutes, you still had a lot of salvageable myocardium that was left. But once you got out to close to 24 hours, there was relatively little that could be salvaged. Well, this set the stage for our current management of acute MI, which is reperfusion, and first started with thrombolytics, which we still use on occasion. But obviously the lessons that we learned there were that the earlier you administer lytics, the more lives you save. And of course, over time, we shifted whenever possible to angioplasty because we could achieve better flow and more reliable restoration of blood flow. So all of this set the stage for what we all know, which is that time is muscle. And so I know that you are working hard and we are working hard on getting our patients who present with STEMI to the cath lab right away. But there's a little bit more to the story. So in the United States, we've done a very good job overall at reducing the time from when a patient presents to getting that balloon open across the artery and restoring flow. So over the last decade or so, we've gone from a median of about 83 minutes down to about 67. And we can often do much, much better than this. The interesting thing is that while we know that time is muscle, the mortality rates over the last decade or so really haven't gotten much better. So the question comes up, why is that? Well, it's possible that we've gotten so good that we've reached a point at which making it even shorter just isn't going to improve things. We've already sort of gotten as good as we can get. These are population studies, so it's also possible that we're just routinely treating sicker patients. Those patients who come to the lab are sicker than might have been referred beforehand. But there's another issue that goes on when you open up an artery and restore flow, and that is the issue of reperfusion injury. And that's what I want to talk a little bit about today. So I think a lot of us experience this situation where you have somebody come in with an acute MI, and you can see here an occluded mid-LED. And it's fairly simple to open up that artery and put a stent in and congratulate yourself. But sometimes what happens is, despite opening up the artery, the patient actually gets a lot worse. And you can see here in this particular patient, we've opened up the LAD, and now they have a swan in, they have an Impella device in, they're intubated, and they've got a TE probe down. So this patient has actually gotten acutely worse after we've restored flow. And why should that be? Well, there's a lot of different types of injury that you can actually get after you restore flow. One is that the myocardium is often just stunned. So it's going to take some time for that muscle to be able to regain its mechanical function. Often after we inflate a balloon and especially put a stent in, we'll see that despite the fact that we've taken care of the lesion, there's no flow. And that's likely related to microvascular problems, either spasm or clot. And that's associated with a much worse prognosis. Of course, we monitor these patients very carefully because they can have lethal arrhythmias. But the other issue is something that we refer to as lethal reperfusion. So what does that mean? Well, from animal studies, we know that if you have a very brief ischemic time, you can have complete reversibility. But after about 20 minutes or so in animal models, you get to this point of irreversible injury. And we know that it's very uncommon that we can actually get an artery open in that sort of degree of time. So we think there's going to be a lot reperfusion injury in almost all the patients that we see. And at least in animal studies, you can see that it probably counts up to about 50% of the final infarct size. So in animal studies, if you just reperfuse, you can often get a lot of salvage. But if you combine that with strategies to reduce reperfusion injury, so-called cardioprotection, you can reduce the infarct size even more. Okay, so why don't we use these more often? Well, the mechanisms of this are still being worked out. The idea is that when you restore blood flow, you actually can introduce a lot of injurious elements. So you introduce what are called chemoattractants. These are cytokines and chemokines that attract inflammation. You release a lot of reactive oxygen species, which can have distinct patterns of injury. There's often sudden calcium overload, which can render cells dysfunctional, and rapid correction of pH can lead to problems with mitochondria, which of course are so important for the function of cells. Well, there are a lot of elements that have been identified in the lab that can actually help with this reperfusion injury, but almost all of them have failed in human studies. So that's an ongoing, subject of research, but I want to talk about a little bit today is whether there are mechanical ways that we can do this. Well, the most common mechanical way that we can help patients who have a myocardial infarction and cardiogenic shock is the balloon pump. This has been around for a long time, and this was studied back in 2012 and published in the New England Journal. So this is 600 patients who presented with an MI and cardiogenic shock. And despite their randomization to balloon pump, those patients didn't do any better. Well, balloon pump is one method, but now we have much more powerful methods to aid the failing heart. And this is just one of them. This is the Impella device. And this is a device that uses a impeller to basically suck blood from the ventricle out into the aorta. So as opposed to about the half liter of support per minute that you can get from a balloon pump, we can get up to about 4 liters of support or maybe even more with these new devices. So has that changed the approach? Well, we know that these devices can improve hemodynamics. They can improve cardiac index, blood pressure, heart rate comes down and wedge pressure comes down, as does PA pressure and many times lactic acid. And there is some intriguing clinical evidence from this study by Bill O'Neill and others. This is the Acute MI and Cardiogenic Shock Registry. And in this particular study, it actually appears that those patients who come in cardiogenic shock with acute MI, if they get a device implanted pre-PCI, they actually have better survival. And it's interesting because you might expect those patients to actually be a higher risk group of patients because for some reason, they decided to put in one of these devices before they did the PCI. But this is just registry data. Well, one group that has been very interested in this is a group out of Boston at Tufts University led by Naveen Kapoor. And he's done a number of animal studies that are really interesting. And this is the basic design of all these studies. You take a pig model and you have it occluded for, say, 120 minutes, the left anterior descending artery, and then you reperfuse. What you compare that to is another group in which you have the same amount of occlusion here, but instead of doing reperfusion, you keep the artery closed and you put in one of these Impella or other devices to support the heart. And then you actually do reperfusion. And the really interesting thing is what they find is that despite the fact that these animals have a longer duration of ischemia, they have smaller infarct size. And he's done a lot of work to look at this in a variety of different models with different timings. And he's seen this consistent approach or finding that when you actually unload the artery with one of these mechanical support devices, even with longer ischemia, you'll get a smaller infarct size. And he's looked at some of the mechanisms. Well, one of the interesting things that's come from this are actual clinical trials. So he started a feasibility trial called the door to unloading trial, took 15 patients, and he randomized them to, both groups, both 25 patients each group, both got a Impella device, but one actually had a 30-minute delay. That's called the delayed group, and one had immediate reperfusion. And what he found was that, indeed, in those patients who were assigned to the delayed, they had a longer time until they had the artery opened. And very small study, but he didn't see a signal of any sort of major injury. So on that basis, there is now a trial that's ongoing throughout the United States. Our group is not part of it, but of a much larger trial where they're looking at this in patients. And the way this works is that it's patients who are having an anterior STEMI, and if they present relatively early after their chest pain presentation, they basically go under the same protocol that the animal studies did. That is that they either get immediate reperfusion or they go to the lab and an Impella is placed and they just sit there and wait for 30 minutes. And so that's going on right now. We don't know what that's going to show. The interesting thing for us here is that we looked at all these studies and we thought there's one group that's missing here. And that is, what if you do unloading with one of these Impella devices, but you don't wait? You do simultaneous unloading and reperfusion. Can you actually get the benefits of unloading without waiting that period of time? And this is exactly what I'll show you from our study. And so what you'll see in this animal study is three groups. One is ischemia with 60 minutes and then reperfusion. One is 60 minutes of ischemia plus another 30 minutes while we unload. And the other group is simultaneous unloading and reperfusion. And this is just an example of work. And Dr. Tandar has been working with us on this project. But we basically just inflate a balloon in the mid-LED to create our infarct model and then let it down at the various time points, plus or minus having that Impella. And what we then do is we take out the heart and we stain. So we can look at the area at risk, right? Which is this whole area here and the red area. And then these paler areas, that's the size of the infarct.
Your time?
Well, what we, yes?
5 minutes more.
Yes. So what we found was that actually it was the group with ischemia and simultaneous reperfusion that had the smallest infarct size. Okay, so what does this mean? Well, in our model, that was the best group. It doesn't mean necessarily that the other studies were wrong at all, but it does raise some questions. So this is the basic question that we had. If you look at the benefits of unloading, you have to balance that against your time delay to reperfusion. So if we did a simple sort of thought experiment, if we were going to wait 12 hours to reperfuse, obviously would not benefit the patient. And we have to remember that we know this from prior studies, that the sooner you can reperfuse, we know the better. And all of the animal studies that we've looked at have really looked at this very early time point. But we're going to see a lot of patients that present later from 6, 12, and maybe further out from their onset of chest pain. Are those patients still going to benefit from unloading? despite the fact that we know that it might have some effect on reperfusion injury. So this really makes us think about whether this is really going to be the strategy moving forward. What about infarct size? What about the territory that's involved? LAD versus RCA, et cetera. And what about the degree of unloading? If we can unload the heart even more, will we have even more benefit of unloading? We just don't know. One thing that we have thought about, though, is that if you're able to put in an Impella and support the blood pressure of the patient, maybe you can give some of those other agents that have been touted for a long time to be effective. And one of those is beta blockers. So there is some work out there that suggests if you can support blood pressure with things like milrinone and then give beta blockers, maybe we can reduce reperfusion injury. So if we can combat the hypotension that we see with cardiogenic shock with an Impella, maybe we can give larger doses of beta blocker and therefore prevent reperfusion injury. So we think that there's lots of more work to be done in this field. We need to know the optimal timing. We need to understand the mechanisms of what this approach might be doing. And we need to think about maybe combining unloading and supportive blood pressure with other agents. Just a little bit of a reminder that the use of these Impella devices, which is gaining steam and we're using them a lot, it does come with risks of bleeding. So if you look at balloon pump versus these other devices, you'll see more bleeding in the group with these Impella devices. And there have been some studies that have suggested an increased death from stroke and bleeding. So I think, we've really made incredible strides. And I want to say that door to balloon is still a very, very important factor. We should all strive to get the artery open as much as possible. But I also think that there probably are ways that we can still improve the outcome of these patients. And reperfusion injury is a big target. If we can develop techniques to reduce that, our patients will do even better than they do currently. And I think mechanical unloading shows promise, but I'm not sure we're ready exactly to delay reperfusion, by 30 minutes to put these devices in. But we'll see the results of that door to unloading trial sometime within the next year. So I'll stop there and I'll thank you for your time and terima kasih.